on glomerular compartment, glomerular lesions. So the present lecture is based on tubulointerstitial and vascular compartment. So I'll use the pointer. Just give me a minute. Okay, so the last lecture was on the glomerular compartment, and what you can see, appreciate here is these structures, these are the tubules, and in between whatever you are seeing, this is interstitial. Okay, so today we are going to discuss about the tubulointerstitial pathology. And as I've told you before also in my first lecture, that whenever there is a glomerular pathology, patient will present with proteinuria or hematuria as the dominant complaints. And whenever there is a tubulointerstitial pathology, majority of these patients will present with raised serum creatinine. That will be the chief complaint. So if there is a patient who comes with rising serum creatinine and no proteinuria or hematuria, you know that the pathology lies in the tubulointerstitial compartment. Okay. So we will start with the morphology of how tubules look like, and when there are some pathological changes which occur in tubules, how will they appear. So to start with, this is a HND stain of the kidney, and which shows that this is a tubule. And what you can appreciate here is that this tubule and there are these small tubules like this, and then there is a large tubule like this, or possibly you can say this large tubule like this. Okay, so these large tubules, you can see the nuclei, you can appreciate these nuclei which are there, and I'll show in the PS stain when I say that there is a brush border. So if there is a brush border in a dilated tubule or a larger tubule, that is a proximal tubule. And when the tubule has narrow lumen and it has no brush border, okay, that is a distal tubule. So it is difficult to pick up on HND section, but yes, this tubule looks like a proximal tubule because it is a dilated tubule and it has got, you can see this line-like thing. And I'll show in the PS stain, this is a brush border. Okay, and brush border is better picked up on a ultrastructure examination or EM, electron microscopy. So this is a PS stain. What it highlights is this is a glomulus, and you can see these tubules, and these tubules are arranged in a back-to-back manner. So the tubular basement membrane can be highlighted better in a PAS stain. You can see these tubules which are arranged in a back-to-back manner. Even at this magnification, you can see these large tubules like this, and in between you can see smaller tubules like this. Okay. So these smaller tubules, what you are seeing in between these larger tubules, similarly you can see the small tubule like this. So all these larger tubules, and this is a vessel. Okay. So all these smaller tubules are distal tubules, and all these larger tubules are proximal tubules. So this is a high magnification of the same. You can see this proximal tubule. What you can see in the PS stain is, you can see this brush border. You can see this brush border which is continuous, which is seen here, and that is a usefulness or a utility of a PS stain. It is a useful stain to pick up a lot of things. You can also appreciate the tubular basement membrane which is there. Okay, and just compare this tubule with this tubule, and this tubule has got a smaller lumen and it is not having any brush border. So it is this tubule is most likely distal tubule, and this dilated tubule with brush border is a proximal tubule. This is a vessel you can see here. So smaller tubules are mostly distal tubules. So you can appreciate here, you can see the brush border in all these tubules. You can see this brush border which is there inside lumen, and this line-like thing which is on the inner aspect of the proximal tubule. Similarly, you can see this brush border here. So this is very important whenever we say there is an acute tubular injury. So this acute tubular injury is a new terminology which we quite recently we are using it. Otherwise, we used to label everything as acute tubular necrosis. So you can see these tubules which are arranged in a back-to-back manner. There is hardly any intervening interstitium. But just see on the PS stain also, the cytoplasm is more granular of these proximal tubules. It is more granular as compared to this distal tubule. You can see this is the distal tubule. It is not as granular as a proximal tubule. The cytoplasm of proximal tubule is granular because they have a lot of mitochondria, and these mitochondria are missing in the distal tubule. So how you can differentiate a proximal from distal is, proximal will be larger. They have bigger lumen. They have got brush border. They have got more cytoplasmic granularity because of more number of mitochondria. As compared to the distal tubules are smaller in size. They have got narrow lumen. They have got no brush border, and they don't show they don't have mitochondria in the cytoplasm. That is why the cytoplasm is not granular. And this is the HND stain to highlight that you can see these dilated tubules at places. You can see this dilated tubules, few of these dilated tubules. You can also see there is some interstitial expansion, because they are at places they are in a back-to-back manner, but at places there is evidence of interstitial expansion. Okay. And similarly, this is a proximal tubule, this is a proximal tubule, but this is the smaller lumen, this is a distal tubule. So what I want to highlight here is this is the HND stain. You can see the brush border. This is like cilia kind of a thing. You can see a brush border, and suddenly this area, there is disruption of this brush border, which is there. Okay. So this kind of a thing suggests that there is an acute tubular injury. And there is very minimal interstitial edema. You can see separation of these tubules from each other. Always remember, whenever we use Mason's trichome stain for assessing fibrosis, it has to be assessed in the renal cortex and not in the renal medulla. So this is the renal cortex. So renal cortex will have glomerulus. Renal cortex will have proximal tubules. It will have distal tubules. But the medulla will not show proximal tubules. Medulla will not show glomeruli. It will show predominantly collecting tubules. Okay. So whenever you do Mason's trichome stain, you have to assess chronicity in the cortex. Okay, and not in the medulla. Because in medulla it will appear slightly bluish, because the tubules are separated from each other, so it will appear as more fibrotic. So never assess Mason's trichome stain fibrosis on in the renal medullary area. You have to assess in the renal cortical area. And whenever we say this biopsy showing chronic changes, we are talking predominantly, we are talking only about renal cortex, and we are not talking about renal medulla. Okay, similarly you can see here. So this is a cortex, and you can see this bluish appearing fibrosis which is there. Okay, so there is bluish appearing fibrosis which is there, and just in renal medulla you don't have to assess fibrosis. You have to assess fibrosis in this. There is some subjectivity in assessing fibrosis, because there is a possibility, there is a probability that I may say that I can see one patch of interstitial fibrosis here, one patch of interstitial fibrosis here, and no significant fibrosis elsewhere. So I'll say possibly I think the interstitial fibrosis is like maybe 20 to 25% or 25% minimum. Okay, but there is a possibility the other pathologists might say I think it is maybe 26 to 30%, but I don't think any pathologist will say it is more than 50%. Okay, but there will be some subjectivity in this. Always remember, when you are assessing fibrosis, you have to ignore certain findings. As I have told you, don't assess fibrosis in renal medulla. Similarly, don't assess fibrosis around a vessel. Okay? Around a vessel, you are going to see some minimal bluish stuff, fibrosis. So don't assess perivascular fibrosis is never assessed. It is always in the interstitium, which is away from the vessels. You have to assess the fibrosis. So another view to highlight that this is a Mason's trichome stain which shows these fibrotic patches, and even at this magnification you can see that there is evidence of segmental sclerosis also. Similarly, this area also it is showing segmental sclerosis. If you remember my last class, this could possibly be the hilar area of the globulus, and this segmental sclerosis possibly is a perihilar variant of FSGS. Okay,
Rajan,
so you have to remember one important thing.
Rajan?
Yeah.
Rajan,
Yes, sir.
Question: how you differentiate edema from fibrosis? I wanted to talk.
Okay, so when
one of the students has asked a question.
Yes, sir, surely, sir. So when I'll be discussing about the cases also, I'll be showing these things. But remember, edema will be more pale. Okay. I know majority of you do routine histopathology and all that. You must be remembering when we say fibrosis and when we say edema in any organ in the body, we say it is mucopolysaccharide, acidic mucopolysaccharide which gets deposited. So if you see pale area, that is more likely to be edema. And if you see more pink looking areas in the interstitium, that is more like fibrosis. And whenever you will do Mason's trichome stain, the dark blue area is more fibrosis and light blue area is more edema. Like in this case, if I have to say which is more edema and which is more fibrosis in this image, I would say this bluishness is more as compared to this area. Okay, this area is pale blue and this area is dark blue. So I would say this area is more fibrosis and this area could be just a interstitial edema which is moving towards fibrosis. So it is very important whenever we report kidney biopsies, whenever there is edema, that means it is an acute injury, and whenever there is fibrosis, that suggests a chronic kind of injury. That means it is an irreversible kind of injury which has occurred. Okay. So in immunofluorescence also, this is a tubular cast, and tubular cast is positive for IgA. So whenever we see that, whenever we say that IgA, whether my IgA is working or not working, remember that tubular cast contains stem phosphoprotein and they are positive for IgA. So when IgA you see in the tubular cast, that means your IgA is working, that means it is a normal tubular cast. And there are some cases where the tubular casts are negative for IgA and they are positive for kappa, or they are positive for light chains. They are positive for a single light chain, then this is a case of cast nephropathy rather than. So what I want to highlight is normal tubular cast are IgA positive. So if you see IgA negativity in the tubular cast, okay, and you see more, and you see kappa or lambda light chains in the tubular cast, okay, that suggests that there is some exogenous material which is getting deposited in the tubular cast. Sometimes that happens that if there are myoglobin casts or if there are hemoglobin casts, they will not stain with IgA, okay. Then you know that most likely these tubular casts are made up of some exogenous material. They are not made up of TAM phosphoprotein. So what I want to highlight by this finding is that whenever we look at the immunofluorescence also, look very carefully. And the most important thing last time also, which I told you, first look at your light microscopy. Come up with your, what is your light microscopic diagnosis, and then you look at the immunofluorescence. Okay, that is very important. So when we say acute and when we say
can I interrupt, Rajan? The other
yes,
broad thought about the interstitium, when you look at and when you look at the medulla, as Dr. Rajan mentioned, you see a lot of interstitium in the medulla, and very little interstitium should be seen in the cortex. Now, if on a good H&D section itself, you start noticing that the interstitium is more visible, then it's pathological. It could be either edema or it could be fibrosis. But you have a hint in the quantum of interstitium that you would see in the. If you see more of interstitium, then you know it's not a normal finding. Yes, Rajan.
Yes, sir. So similarly, what Sir Jairam also mentioned, that you see these tubules which are separated as I've shown here. So there is some separation of the tubules. So that suggests that, and you see this is pale. It is not pink. So since it is pale, it is more like edema rather than interstitial fibrosis. So, okay. So when we say it is acute and when we say chronic, so acute terminology, sometimes we use this terminology acute tubular necrosis or acute tubular injury. So whenever there is a pathology in the tubules, that is, whenever there is acute injury in the tubules, we label it as acute tubular necrosis or acute tubular injury, which I have already shown. There will be dilatation of the tubules, there will be loss of brush border or disruption of the brush border. There will be interstitial edema plus minus interstitial inflammation. So if you see interstitial edema and dilatation of the tubules, loss of brush border, you label it as acute tubular necrosis or acute tubular injury. But when in the areas of interstitial expansion or interstitial edema, you see infiltrate also, then you label it as acute interstitial nephritis. So for example, if there is no tubular injury and you see interstitial expansion and there is interstitial inflammation, okay, then you label it as acute interstitial nephritis. But when you see tubular injury, that means there is ATN. Along with that, there is interstitial inflammation. You label it as acute tubular interstitial nephritis. For example, look at this case. So you can see these tubules. Even at this magnification, you see the interstitium is expanded. Interstitium is expanded, and it is very pale. It is not like very pink looking interstitium. Even at this magnification, you see some orange color cells. So there is a lot of background noise which is coming. Okay, so you see a lot of eosinophils in the interstitial infiltrate. Okay, and this is a high magnification which shows that a lot of eosinophils are there in the interstitium. Okay, when you see a lot of eosinophils in the interstitium, you should think of some kind of a drug-induced tubular interstitial nephritis. And what you can appreciate here is there is interstitial edema, there is a lot of interstitial infiltrate, there is tubular injury because tubules are dilated. So it is like acute tubular interstitial nephritis. On the other hand, when we say chronic, so chronic in relation to tubules, they will show tubular atrophy. So tubular atrophy means that instead of dilatation of the tubules, there will be narrowing of the lumen, there will be thickening of the tubular basement membrane, which I'll show you now. And instead of interstitial edema, there will be interstitial fibrosis. So it is very similar to what we report when we report liver biopsies also. So we say there is a portal tract edema, okay? And you know that there is pale looking portal tract. And when you say there is portal fibrosis, so it is more pink looking, more dark pink looking portal fibrosis. Okay, similarly in kidney also, when you say interstitial edema, it is pale, and when you say interstitial fibrosis, it is more pink, it is more chronic. So in both the compartments, so when there is chronicity in the tubules, they will appear as atrophic tubules, and whenever there is chronicity in the interstitium, it will appear as interstitial fibrosis. And when you see evidence of inflammation in the areas of fibrosis, that is called as chronic interstitial nephritis. And when you see tubular atrophy with interstitial fibrosis, and there is some interstitial inflammation also in the areas of fibrosis, you label it as chronic tubular interstitial nephritis. So instead of acute tubular interstitial nephritis, we now label this thing as chronic tubular interstitial nephritis. For example, look at this biopsy. This is a HND stain, and HND stain is showing, as compared to the edema which I showed you in the previous slide, where I said ATI and acute tubular interstitial nephritis, a lot of eosinophils. What you can see is a lot of pink looking stuff in the interstitium, okay? And these tubules also, as compared to the tubules where you can see lumen here, you hardly see any lumen here. And here it is very important that when you do PAS or silver stain, you will come to know that actually in this area, what I am showing you, actually there are some atrophic tubules also, which you are not able to pick up on a HND stain. Or moreover, we are looking at a low magnification. Now this is a PS stain of the same area, and what you can appreciate is there is a lot of tubules which are like atrophic tubules because they have got narrow lumen. And always remember, when you see prominent vessels, even at low magnification in a kidney biopsy, that means there is some pathological change which is occurring in these vessels. You can see these glomeruli, there is expansion of the urinary space, that means there is some ischemic wrinkling of the glomeruli which is occurring. And look at the tubules. As I show the high magnification, you can see these tubules, and these tubules have got a very thick and a wrinkled tubular basement membrane, and they hardly have any lumen. You hardly see any lumen. You can see a lumen here, but you don't see lumen here. You don't see any lumen here. You see a lumen here. You see a lumen here. Okay, and these are all atrophic tubules. Look at these tubules. These are all atrophic, severely atrophic tubules. These are like severely atrophic tubules where there is no lumen, and these are like moderately atrophic tubules. And then there are some atrophic tubules where the thickening of the tubular basement membrane is there, but the lumen is there is slight narrowing of the tubular lumen rather than significant narrowing. So these are like a mild tubular atrophy. Still higher magnification to highlight the same thing. You can see a tubule like this, and just compare this tubule with these tubules, or this tubule and this tubule, and you can see there is significant corrugated appearance of the tubular basement membrane. So there is significant wrinkling of the tubular basement membrane. In addition to that, there is a lot of fibrosis also which is occurring in the interstitium. And this is a Mason trichome stain which shows that there is wrinkling of the glomerular basement membrane, and there is expansion of I told you this terminology. Glomerular basement membrane terminology has to be used only when you report ultrastructure examination. So glomerular capillary wall. Okay. So here you can see the on the Mason trichome stain, this is ischemic wrinkling of the glomerulus, and you can see there is a lot of bluish stuff. Even the tubular basement membrane is appearing very bluish. That suggests there is a lot of fibrosis which is going on in this biopsy. A higher magnification of the same. You just compare this tubular basement membrane with this tubular basement membrane, and you can see this is like a normal looking tubular basement membrane, and this is like a very thick looking tubular basement membrane. Just compare this also. Okay. So all these findings suggest a chronic changes, and even in the glomerular compartment, you will see a lot of fibrosis. So there is glomerular sclerosis, which is occurring, and so there are 2-3 patterns of tubular atrophy which I want to highlight. So the pattern of tubular atrophy where you see wrinkling of the tubular basement membrane, like for this, in this case, you can see this wrinkled kind of corrugated tubular basement membrane. This is called as this is one pattern of tubular atrophy, which is most common pattern of tubular atrophy you see. On the other hand, just compare this tubule with this tubule, okay, with this tubule, which I have highlighted by an arrow. So this tubule is showing the tubular basement membrane is not thick, it is not corrugated just as compared to this one. It is a thin tubular basement membrane, but look at the uh, colloid-like TAM phosphoprotein casts which are there, and look at the tubules, tubular epithelial cells. The tubular epithelial cells have got a clear halo around it. Okay, as you people you do histopathology, you remember that we see endocrine cells. They show nuclei with a halo around them. Okay, and you also see this kind of halo if you report lymphomas, monocytoid cells or marginal zone lymphoma show this kind of a halo around it. Okay, hairy cell leukemia, you see that this kind of halo kind of appearance, you can see that. So this pattern of tubular atrophy where the tubular basement membrane is not as thickened as compared to the other tubules. The tubular basement membrane is thin, but the lining tubular epithelial cells, they show a halo around them. This pattern of tubular atrophy is called as endocrinization pattern of tubular atrophy, and it is said that endocrinization pattern of tubular atrophy is commonly seen in renal artery stenosis or in vascular ischemia. Okay, so this pattern of tubular atrophy is like, this looks like thyroid to us. So this is thyroidization of the tubules, and it is said that thyroidization of the tubules you get to see more commonly in chronic pyelonephritis or chronic tubulointerstitial nephritis. Okay, and you see more ischemic wrinkling of the tubular basement membrane, more endocrinization pattern in cases where there is a vascular ischemia, hypertension, or some kind of a vascular compromise system. And sometimes these casts, tubular casts, they are very broad. So these are called as broad hyaline casts, and whenever you see broad hyaline casts, it suggests a chronic kidney injury or CKD. Okay, similarly, you can see these broad casts. One important thing, though they are broad, but they are PAS positive. Okay, they are not PAS negative. You may say that this cast on this side, it appears PAS negative. Yes, it is weakly PAS positive, or you may say negative, but majority of these casts, the large looking casts, they are PS positive. The other thing is, look at the lining epithelium. It is very flattened, and that is a feature of broad hyaline cast. I'll show you one case how to differentiate these casts from cases of cast nephropathy. The cast nephropathy casts, they are mostly PAS negative or very weakly PS positive, but the surrounding tubular epithelial cells, they will react to that cast material. Why they will react? Because it is not endogenous protein. It is some exogenous substance which is getting deposited in tubules. So tubular epithelial cells will react to that exogenous material. That is why you see multinucleated giant cells or tubular epithelial cells showing a lot of reactive changes. Okay. Whenever there is a tubular interstitial pathology, the glomerular compartment will also get involved secondarily, and there could be ischemic wrinkling of the glomeruli. You can see these expansion of the urinary space. This is like ischemic wrinkled glomeruli, or some may say label this glomerulus as a glomerular cystic kind of a change. As I've told you, if you see thick walled blood vessels at low magnification in a kidney biopsy, that means they are pathological. So all these patients who have chronic tubular interstitial nephritis, there will be secondary involvement of the glomerular compartment. Similarly, the blood vessels will also show hypertensive changes or hyperplastic changes. Okay, and this is like when you look at this biopsy on a mesenteric stain, you can say, yes, I'm looking at a fibrotic biopsy. I'm looking at a very chronic, irreversible damage to the kidney has occurred. Okay.
So can I interrupt,
second,
Rajan? Just a moment.
yes.
One very basic thing all of you should remember, that in the kidney, the definition of acute interstitial nephritis and chronic interstitial nephritis is not based on the kind of inflammatory cells. In other tissues, when you see neutrophils, you call them acute, and when you see lymphocytes, you call them chronic. When you see histiocytes, you call it subacute. Whereas in kidney, most of the interstitial nephritis will have the lymphoplastic and histiocytic infiltrate. Very rarely you get neutrophils, which would be there in bacterial infections or ascending infections. So the criteria to identify it as acute interstitial nephritis versus a chronic is, in acute, you will not have tubular atrophy, you will not have fibrosis to the extent that you would see in chronic. So whenever there is fibrosis or a tubular atrophy, regardless of the kind of inflammatory cells, you call it chronic. Whereas if there is no fibrosis, there is more edema, and there is not much of the tubular atrophy, you call it acute. That's the basic difference in the reaction of the interstitium of the kidney to inflammatory process. Am I right, Rajan?
Yes, sir. Very valid point, sir. Thank you. So, shall we start with the cases, sir?
Sure.
So we'll start with case 1. Yes, Dr. Megha. Dr. Megha? So if Dr. Megha is not there, Dr. Vartika? Dr.
So
Vartika?
we'll have to unmute Dr. Vartika. Just 1 second, sir.
Okay. So I'll read the history. This is a 27-year-old male, dialysis dependent acute kidney injury. AKI is acute kidney injury, secondary to acute gastroenteritis. Urine protein is 3 plus, serum creatinine is 11. So the clinical possibilities are acute tubular necrosis or acute interstitial nephritis. So Dr. Vartika, you are unmuted now.
Sir, I think we can ask Dr. Purvi. I have requested Ruchi to unmute her.
Okay, not a problem. So Dr. Purvi?
Yes, sir.
Yes, Dr. Purvi from DMC, Ludhiana. Yes, tell us. So
Yes, sir.
looking at this, Dr. Purvi, so as you can go through the history, this is a 27-year-old male. He has serum creatinine of 11. Okay. So
Yes.
the clinical possibilities are ATN. Okay. And the second possibility is acute interstitial nephritis. So if there is a biopsy, so we have to look at the biopsy now. So if, for example, if it is ATN, okay, what will you see in the biopsy?
So if we can see tubular damage, we can see tubular necrosis. Apart from it,
Okay.
loss of brush border epithelium. If we are specifically talking about acute tubular nephritis, apart from the dialysis dependent, shows that there is already some chronic damage in the kidney, and then there is proteinuria also indicating glomerular damage as well, and raised creatinine is indicating towards tubular injury.
So tell me one thing. So that means most likely the nephrologist who has sent this biopsy, he never thought about why there is significant proteinuria, 3 plus kind of proteinuria is there. Always remember, so whenever this patient is dialysis dependent, so he is not able to make that much of urine. Okay. So whenever the patients are not able to make up that much of urine because they are dialysis dependent, you will never be able to collect a 24-hour urinary estimation. You can't do. So it will be like a spot urine sample you'll get. Whatever little urine he is producing, you are going to run that. So, and this is a very concentrated urine. And sometimes in a concentrated urine, you may get increased protein also. Okay. So many times the nephrologist will ignore this kind of a 3 plus or 2 plus kind of protein which is coming in a concentrated kind of a urine. That could be the possibility. That's why he never thought of that there could be some glomerular pathology in this case. Okay, that could be the reason. So if it is, so we'll straight away we go to the case. Yes, Dr. Please describe. First tell me, is this a HND stain or a PAS stain?
So this is a PAS stain because the basement membranes are highlighted. So
okay, very good.
So we can see two glomeruli in this section, and both these glomeruli are showing mesangial expansion by an extracellular material, amorphous material. It is looking like weakly PAS positive, and apart from that, we are also able to see extensive tubular damage. There is dilatation of tubules and simplification of the epithelium. There are the TAM hospital. They are cast which are disrupting the tubules, causing tubular damage, and there also the tubules are apart. There is fibrosis, edema, and also inflammatory infiltrate. And in the as we come below, we can also see atrophic tubules, which are smaller in size and showing wrinkling or corrugation of the yes, sir, these one.
Okay, good, Dr. Purvi. So very good. We'll go to the next image now. Yeah, tell me.
So this is the high power. On high power, again we are able to see that there is some amorphous extracellular material, pink material deposited in the mesangium. It could be a myeloid, which is on the further slides. We've seen that it is Congo red positive. So I'm saying it's a myeloid. And
okay.
Again, this is the cast in the, and which is along with cast, we're also able to see some inflammatory infiltrate in the tubules, causing the
Okay.
tubular reaction.
Okay. So this is Congo red stain.
Yes, sir.
Actually, I was expecting that there is a possibility that whatever material you are seeing in these tubules, this is also like PS weakly positive. I thought that this may turn out to be some exogenous kind of material, and there was some reaction also. But remember that whenever there is some kind of a, if there is a tubulointerstitial pathology, if there is lot of inflammation in the interstitium, there could be one or two occasional tubules which will show this inflammation going into the tubular lumen also. It may appear like a granulocytic cast. So presence of an occasional granulocytic cast, don't jump to a conclusion that it is a pyelonephritis. Okay, so there has to be significant number of tubules with granulocytic cast to be labeled as acute pyelonephritis. So this occasional cast you can see even in a severe acute tubulointerstitial injury. So this is a Congo red stain, and it shows that these deposits are congophilic deposits which are there.
Yes.
And in the tubules, the material which was there, it is not congophilic. So likely it is not a amyloid kind of material which is there. So what is the next step?
Sir,
So we did kappa lambda.
yes, sir.
Why
It
we
is
did kappa lambda, Dr. Purvi?
Sir, to see whether the cast is, to differentiate the cause of the, to rule out cast nephropathy. It is
No.
equivocal.
So the thing is, what do you think? What I'm highlighting here, is this a globulus or a tubule?
Tubule.
These images.
Is
Oh no, Dr. Purvi, this is not tubule, this is a globulus. Okay, so you can see these are the globular capillary roots, and you can see this material. This is an expanded mesenterium, and similarly you can see this expanded mesenterium here. So there is a, you can say there is a very minimal kind of staining with kappa, and there could be trace to 1+ staining with lambda. But for a restriction, there has to be very bright staining for one light chain, and the other light chain should be completely negative. So we did kappa lambda to rule out the possibility of any primary amyloidosis. Okay, there is no definite light chain restriction, so it is definitely not a primary amyloid deposition. The next step is these are the cast. Okay, so the cast also they are showing there is a 1+ staining in the kappa, but there is some 2+ staining and 1+ to 2+ staining in the lambda also. Okay, but there is no restriction other. So one light chain has to be completely black, it has to be completely negative. Other should be 3+, very strong, to be labeled as cast nephropathy. So when you see restriction in the tubular cast, that is called as cast nephropathy. Okay, so the first image, it just points out that the amyloid deposits, they are not primary amyloid, they are not primary light chain associated amyloid. Okay, it is not like multiple myeloma or plasma cell neoplasm. Okay, and the tubular casts are not showing any definite restriction. So these are some of the tubules which are showing these protein absorption droplets. They are also showing similar staining with kappa lambda. So definitely no light chain restriction. So what is the next step? We did, what is SAA?
secondary amyloid stain positive for, it is showing that the amyloid deposition is due to AA amyloid secondary amyloidosis. It is highlighting wherever the amyloid is deposited in the glomerulus and in around the blood vessels.
Okay, it is in the glomerulus, it is around the blood vessels, and also in the interstitium also you can see this deposition. Okay,
Yes.
Okay, around the vessels you can see. And what is the full form of Dr. Purvi? SAA?
Secondary amyloid A inducing.
Okay, so this is serum amyloid associated protein.
Sorry.
Okay, so serum amyloid associated protein, this you see mostly with the post-inflammatory amyloidosis or secondary amyloidosis. And post-inflammatory secondary amyloidosis, majority of the times is secondary to some kind of a chronic inflammatory disorders like tuberculosis, bronchiectasis, arthritis, and all that stuff. Okay. Now the thing is, this explains, okay, 3+ protein, whatever was going on. So we know that whatever protein we thought that it is concentrated urine and all that stuff, it is actually, there is a cause for this proteinuria, and that is amyloid. But tell me one thing, have we explained 11 creatinine of 11 in this patient?
Sir, yes, we have seen tubular damage in the.
Okay, so we are seeing dilated tubules with simplification of tubular lining. There is interstitial expansion, and you can see there are eosinophils also. These are tubules which are separated. There is interstitial infiltrate. There are eosinophils in the biopsy. So there is secondary amyloidosis, okay. Along with that, there is acute tubular interstitial nephritis. Now this patient, if you give steroids to this patient, at least the tubular interstitial damage will respond to this to the steroid therapy, because there is significant infiltrate in the biopsy. So this will respond to steroids. If you don't give steroids to this patient, this acute tubular interstitial nephritis or acute interstitial, the interstitial infiltrate will become more chronic, and then there will be interstitial fibrosis which will set in. And once the interstitial fibrosis set in, then it becomes more like an irreversible kind of a damage or a chronic kind of a thing. So at present, since there is interstitial edema and we are seeing interstitial fibrosis, interstitial edema, and there is interstitial infiltrate, so it is consistent with more acute tubular interstitial nephritis. Okay, just a moment. सर मैं आपको कॉल कर रहा हूँ, आई एम इन अ मीटिंग. ओके ओके, sorry. So this is secondary amyloidosis and acute tubular interstitial nephritis. Sir, you want to add something, sir? Dr. Jairam?
No, Rajan, I think you can carry on.
Okay, sir. So we go to the case number 2. So case number 2, yes, Dr. Megha. So Dr. Megha is still not there. Dr. Vartika?
Yes, sir.
Yes, Dr. Vartika. So this is a 46-year male with progressive rise in serum creatinine, alopecia totalis, history of weight loss, ANA is 1:320. Very chronic, very acute interstitial nephritis. With this kind of a clinical picture, what do you expect that this patient can have? This patient has alopecia totalis. Yeah, tell me.
So there is a progressive rise in serum creatinine that indicates tubular pathology, and there is also hair loss and weight loss along with ANA positive, and that indicates towards autoimmune disease.
Okay, good, great. So we go to the biopsy. What do you see?
In this low power view, we can see 3 glomeruli along with atrophied tubules, and in the background, dense inflammatory infiltrate.
Okay.
And
so I think at this magnification, what we can see is there are possibly these 3 glomeruli which you picked up, and there are these 2 small looking glomeruli also. So you can see there is expansion of the regional space. So most likely these are some ischemic looking glomeruli. So what I would say is at this magnification you can see some pink stuff and you can see some blue stuff. Okay. On this magnification, if you say I think these are plasma cells and lymphocytes, so that would not be great. So we go to the next magnification. Tell me, Dr. Vartika, what do you think?
So in this micrograph, we can see tubules are dilated and blood vessels is also seen, and some tubules are more eosinophilic. So these are normal tubules in the big circle.
Okay. So what I want to highlight is, Dr. Vartika, just look at this tubule. This is like a normal looking tubule. Look at this tubule. This is like a normal looking tubule. But look at these tubules in the big circle, okay, where I put 3 tick marks, okay. So these are the tubules which are more atrophic. You can see these normal looking tubules which are there, okay, and these are more atrophic looking tubules. So at this magnification, you can see that there is some tubular atrophy, there is some interstitium which is more pink looking. So there is some interstitial fibrosis, and there is inflammation, dense inflammation also, which is there in the interstitial compartment. So this is a high magnification. So what do you think? What are these cells?
So few mononuclear inflammatory infiltrate along with some plasma cells and plasmacytoid cells along with eosinophils.
And binucleated plasma cells, possibly a binucleated plasma cells. Lot of plasma cells. Okay, they are scattered. Possibly these are RPCs. Occasionally scattered eosinophil. Okay.
Yes.
What else? And you are seeing these kind of cells. So these could be some histiocytic cells also. Okay.
Yes, sir.
Or
yes, sir.
Less likely these are fibroblastic cells, but more like histiocytic cells. So what do you think this cell is?
So giant cells are also seen in this.
Yeah.
and
So there are giant cells also which are
keloid
there.
cells.
So what do you think? So what do you think this is?
This is dense inflammatory infiltrate and most probably granulomatous
Yeah.
interstitial nephritis.
Yeah, this is like a granuloma which is there. Very good. So it is granulomatous tubular interstitial nephritis. Tell me one thing. Do you think there is caseous necrosis in this?
Yes, sir. This can be cases
So
necrosis
you
because,
feel that
sir, architecture is not preserved. That's why we can say that cases necrosis is there.
okay. Oh, okay. So I never thought that there is some caseous necrosis in this. I thought that there are just granulomas, non-necrotizing epithelioid cell granulomas with occasional these kind of giant cells. So we did IgG. So the interesting part is in IgG you are seeing whenever there are plasma cells in a interstitium, IgG will pick up those the plasma cells will pick up that IgG, and there will be some of these cells which will shine. So these are all like plasma cells. Okay, and that is a possible reason you will see a lot of background shine also. So as compared to any previous cases which I've shown you, so there is a background shine with IgG. Whenever you see a background shine with IgG, think of some kind of a either there are plasma cell rich infiltrate which is there, or there could be some kind of underlying autoimmune disorder which is producing this kind of thing. So it is granulomatous tubular interstitial nephritis, which you are absolutely correct. After that, a EUS guided FNAC was also performed for mediastinal lymph node. Okay, and it
Yes.
shows granuloma, non-necrotizing granuloma. So actually this patient was a case of sarcoidosis. ACE levels were high, and tuberculosis PCR culture was TB PCR was negative. So it was a case of sarcoidosis. And sarcoidosis, many times in biopsies we see granulomatous tubular interstitial nephritis. Commonly whenever we see granulomatous tubular interstitial nephritis, the common causes are drugs, and second possibility is sarcoidosis, which you have to keep in mind. Tuberculosis, obviously, living in India, you have to keep tuberculosis as one of the possibility. And but commonly you don't get to see tubercle granuloma in a routine kidney biopsy. In a nephrectomy specimens, when there is a history of uh, genitourinary tuberculosis and nephrectomies, then you can see those kind of cases, necrosis, and all that stuff. But commonly, in my experience, what I've seen, whenever we label anything as a granulomatous tubular interstitial nephritis, the common causes are drugs and sarcoidosis. And sometimes you can also see calcification, microtubular microcalcification also in cases of sarcoidosis. If a patient is if they say that there are mediastinal lymph nodes and there is increased serum creatinine and you do a biopsy, you see a lot of calcification. You see occasional giant cells with calcified thing within the giant cell, calcified structure within the cytoplasm of the giant cell. These things are commonly seen with sarcoid kind of a thing when we report kidney biopsy. So this was a granulomatous tubular interstitial nephritis, and finally it turned out to sarcoidosis. Can we go to the next case, sir?
Yeah, just one point. When you see granulomas, and especially you need to look for the localization. If you find that the granuloma is around a vessel or a vascular centric, then you keep vaginous also in your mind. That because even that can present with granulomas. Of course, in vaginous you would have other features like crescents and all those things. But just from a purely tubular interstitial point of view, one of the reasons you could see granuloma is a vascular centric granuloma of vaginous granulomatosis.
Yes, absolutely correct, sir. Yeah. So this is a very valid point. So if you see granulomas in relation to a vessel, so granulomatous vasculitis is a thing which you have to say that. And not very commonly you see the granulomatous vasculitis, but occasional cases you can come across these cases where there could be only isolated granulomas and isolated vessel with evidence of vasculitis and granuloma. So we go to the next case. So next case, Dr. Krishavani from TMH.
Yes, sir. Yes, sir.
So Dr. Krishavani, 56-year male patient was under evaluation for a pancreatic head lesion. So PET scan. So obviously you are from TMH?
Yes, sir.
Right case for you. So PET scan shows mildly enhancing metabolic active mass is seen involving head of the pancreas with proximal CPT dilatation Other metabolic active masses are also seen involving the uncinate process, neck and body of pancreas. Increased surrounding fat standing is seen, metabolic active lymph nodes, left and right, iliac and inguinal lymph nodes. So what is your clinical possibility you will think of before looking at the biopsy? Now you have already seen the images, but what is the likely possibility you will think of in this kind of a thing, in this kind of a clinical picture?
Some malignancy would
Malignant.
be my first thought.
So in the malignant lesion also, what are the first one or two differences you will consider? You will consider adenocarcinoma or you will consider more lymphoma?
So the pancreatic looks like an adenocarcinoma, but multiple enhancing lymph nodes will definitely should have a differential of lymphoma as well.
Yeah, you will keep a possibility of lymphoma as well. So these are the blood counts and biochemistry like this. So tell me, do you think there is any abnormality in the lab investigations?
So the CA 19.9 is elevated, which can be towards a adenocarcinoma. Then
So tell me, yeah. Sorry, please go on.
so
Yeah.
and
So do you think for a pancreatic malignancy, a CA 19.9 of 88.2 is significant to cause inguinal lymph nodes and all that stuff?
yeah.
So I expect for adenocarcinoma pancreas to produce significant lymphadenopathy or metastatic deposit in the lymph node, I expect CA 19.9 to be in thousands.
Yes.
Yeah. So it is not that high. It is increased, but it is not that significantly high. So anything other than this, you find that this lab parameter is abnormal.
So the UBCs are definitely, the TLC count is definitely very high.
What about 1.85
serum?
serum creatinine? Do you think it is normal?
Yeah.
So it is normal. See, the thing is, this patient went to a gastroenterologist. Obviously, he went to a gastroenterologist, so he ignored this creatinine of 1.85. Thought everything is fine. But they were also not suspecting adenocarcinoma as the first possibility, so they went ahead with the pancreatic biopsy. It is not very commonly you come across pancreatic biopsies. So pancreatic biopsy was done, which showed fibrotic tissue only. It was inadequate for opinion. This is a favorite line as histopathologists: correlate clinically. Okay, we love writing this. Okay, and they also correlated clinically, and this patient was started on steroids. Empirical steroids was started, 20 milligram per day oral steroids. Now the present complaint was there was rise in serum creatinine for 1.85 to 6.2, and urine routine showed trace proteins and 5 to 6 RBCs. Ultrasonography showed bilateral bulky kidneys. ANCA, if you remember my last presentation on glomerular compartment, ANCAs are always awaited, and they were awaited in this case also. So since there is a sudden rise in serum creatinine in a span of few days or weeks, from 1.85 to 6.2, it is the clinical presentation is like RPRF, rapidly progressive renal failure. Okay. So do you want to comment on anything else? So
No, sir.
tell me one thing, Dr. Trisha Mani. Tell me one thing. Do you think there could be crescents in this biopsy because there is rapidly progressive renal failure?
Yes.
And one of the cause for rapidly progressive renal failure is crescentic GM.
Eccentric, yes.
So
Yes,
if
sir,
you look
should
at
expect.
urine routine microscopy, it shows very trace protein and just 5 to 6 RBCs. Had it been a crescentic GN, you would have seen a proteinuria which is significant. You would have seen RBCs which are also significant. Okay.
Yes.
So look at this. It looks like there is less likelihood that there will be a crescentic morphology. You will see on the biopsy. So come to the biopsy findings. Tell me. First of all, is it a pink looking biopsy or is it a blue looking biopsy?
It's a pink looking biopsy.
Great. So you'd see that 90 to 95% it is pink looking biopsy, and blue looking stuff is only these occasional lymphoid aggregates. Okay. So tell me one thing. At this magnification, it is a very pink looking biopsy. What are the possibilities you would think of? It is a pink looking thing, whatever is there. Okay. Do you think, had it been edema, will it be that pink? Or it is most likely fibrosis, which is producing so dense pink kind of
Edema would be a
interstitial.
lighter pink. It would be more like a fibrosis.
Yes, it would be more like fibrosis. Great. Okay. So whenever you see pink looking stuff, what are the things you will think of? So so tell me one thing. One, you have said interstitial fibrosis could be there because it is more pink looking. The what kind of infiltrate will be more pink looking? In any histopathology thing, I'm not talking about kidney biopsy. In any histopathology stuff, or maybe I would say lymph node. You can use any tissue. If it is a very pink looking thing, one is fibrosis. You will think of what kind of inflammatory cells will be more pink looking. Those cells which have abundant cytoplasm. Okay, so the cells which have abundant cytoplasm are like histiocytes. They have abundant cytoplasm. Plasma cells, they have abundant cytoplasm. Had it been a mature lymphocyte, it will not be pink looking, it will be more blue looking kind of biopsy. Okay. So we go to high magnification. It is not high or medium power magnification. So you can see the glomuli which are there. And glomuli, at least at this magnification, they look fine. There are no crescents. So it is not a crescentic morphology. So what you can see is you can compare these tubules which are dilated and just compare these smaller tiny tubules. They look atrophic. But these tubules are separated from each other. So there is significant interstitial expansion. And as you have seen, that the interstitial expansion is not because of interstitial edema. It is because of interstitial fibrosis. Okay. So you can see a lot of pink stuff. You can see these round aggregates. Okay, I'll just go through these. So okay, so there is a lot of infiltrate in this areas of fibrosis. Lot of infiltrate, and this is edema. This is a Mason trichome stain which also show dense fibrosis. Now we look at the high magnification of the infiltrate. What do you think these cells are?
They are plasma cells. Majority
Okay.
of them are plasma cells.
Okay, tell me one thing. Do you think it is a, you are from TMS, do you think it is a plasmacytoma?
No, sir.
Why?
It's rare in the kidney that the brain.
No, but don't, we will not do any immunohistochemistry. On morphology, do you think it could be a plasmacytoma?
No, so
So,
there are other inflammatory cells as well.
okay, so the thing is, whenever we see any plasmacytoma, these plasma cells will be in solid sheets. So what you're seeing is there are plasma cells, but there is intervening fibrosis also which is there. Okay. The other thing is, look at these plasma cells. Majority of them, they have got a perinuclear HOF, perinuclear clearing. It is said that mature plasma cells will not show perinuclear HOF. You can see this perinuclear clearing around these plasma cells. Okay. So all these findings, and intervening there is fibrosis, okay, which is not a finding you get to see in plasmacytoma. And there are some fibroblastic cells also which are there in between these plasma cells. This is a vessel, and the inflammation is also extending into the veins or vessels. So this is called as phlebitis. Okay. So there is a lot of interstitial fibrosis. There are a lot of plasma cells. There are few scattered eosinophils also. Okay. And there is phlebitis. Another finding. So there are a lot of plasma cells. You can see all these sheets of plasma cells. Possibly scattered eosinophils. There are fibroblastic cells. There is pink-looking fibrosis which you are seeing in the background, and this is a PAS stain which shows these atrophic appearing tubules in this dense fibrosis. Again, the similar kind of thing. So some areas, so as compared to the other images, this image is showing more fibrosis and less inflammation. So you see more fibroblastic cells than inflammatory cells. Look at the IgG. IgG is showing a very granular kind of staining along some tubules. So always remember, whenever there are autoimmune pathologies, you will see some granularity along the tubular basement membrane. Okay, so there is some minimal granularity along the tubular basement membrane which is there. Okay. So kappa lambda So this was interesting that in kappa lambda, the lambda was showing some positivity in these. There was positivity in these plasma cells, but there was no significant positivity in kappa. So I will not go into that thing. We got the serum free light chain assays also, which were not showing any restriction. So IgG, there was all these plasma cells were highlighted by IgG, and we did IgG4 stain, and IgG4 stain constitutes more than 30% of these plasma cells which are IgG positive. They are positive for IgG4 stain. Okay, so this is a IgG4 related tubular interstitial nephritis, and you have to remember, and many times IgG4 related tubular interstitial diseases are associated with autoimmune kind of pancreatitis also. So most likely the pancreatic lesion, the pancreatic head mass is autoimmune pancreatitis or IgG4 related pancreatitis. This patient received, and this was the follow-up of this. So if you look at the IgG levels, they were significantly high as compared to IgA, IgM, and IgG4 also was significantly high. So this patient was started on 60 milligram per day steroids for 4 to 5 weeks. Initially, by the gastroenterologist, it was like 20 milligram per day. So this is a fibrosis which is reversible fibrosis. So if these patients receive high dose steroid, they will respond. But the moment you taper down steroids, the fibrosis will again start appearing. So that is a problem with IgG4 related disease. We don't know how long to give steroids. Okay, and as you know, there are side effects of steroids also. So the present serum creatinine is 0.8 and the pancreatic lesion reduced in size. Okay, so there will be some cases, or this is not the same case. There will be some cases of IgG4 related disease where all the glomuli will be sclerosed. There will be significant fibrosis. There will be plasma cells which will be there in the interstitium. Okay, as you can see, a lot of plasma cells in the interstitium, but the fibrosis is dense. And IgG, when you do IgG immunofluorescence, you will see a lot of background IgG staining, and the IgG staining is also seen along the tubular basement membrane. Kappa lambda is not showing any restriction. IgG4 is showing slightly increased thing. So what I want to highlight is the first case is more like a fibrocellular kind of a phase of IgG4 related disease, or more cellular phase. The second case where I show a lot of globally sclerosed glomuli, this case, it is more like a more toward the fibrotic thing. And sometimes these patients will present with mass-like lesion like this. Okay, this will be like a pseudotumor. This will be like a pseudotumor. So IgG4 related pseudotumor can also present like this. So IgG4 related disease is a distinct clinical entity with various patterns of organ involvement, and there is no single serological or other test exists to diagnose this entity, this disease definitely. But you have to keep in mind this disease, and it is always a clinical, histopathological, and immunophenotype or immunohistochemistry which will help. And many times there will be increased IgG4 plasma cells in the biopsy, and the serum IgG4 levels will be normal. Okay, so you have to correlate everything together. So it is a combination of histology, immunophenotype, clinical, radiological, and lab features which will make this diagnosis. So come to the next case. So you want to add something, sir?
I was curious to know what the lymph nodes showed. Even they showed IgG4?
So the lymph node biopsy was not done, sir. It was only the pancreatic biopsy, and then the kidney biopsy was done. Lymph node biopsy was not done.
Did they regress with steroids?
Yeah, they regress. Everything regress with steroids. So we have seen occasion cases of IgG4 related thing in lymph nodes also. Now there is a concept which is coming, that Rosai-Dorfman disease, Castleman's disease. They are not Castleman's, the Rosai-Dorfman disease and IgG4 related disease. They are somehow closely associated with each other. So can we go to the next case, sir?
More than Rosai-Dorfman, it is the Kimura's disease and IgG4. They are linked to each other.
Kimura's I am not sure, sir, because Kimura's is more like a epithelioid hemangioma, angiolymphoid hyperplasia, angiolymphoid hyperplasia with eosinophilia, and that is more in the head and neck region, post-auricular, pre-auricular or post-auricular location. You get to see Kimura's disease. I think, sir, Rosai-Dorfman, because you see a lot of plasma cells in Rosai-Dorfman with emperipolysis, so it is said that Rosai-Dorfman and IgG4, these are more related kind of things. So I'll check, but I'll check both. So
Nice case.
shall we go to the next?
Yeah, please.
So we go to the next case now. Dr. Utkarsh. 51-year male, Dr. Utkarsh. So this is a post-renal transplant, but no problems. I know that we are looking at native kidney biopsies, but what I want to highlight is that these diseases will be seen even in post-renal transplant cases. So post-renal transplant, 2014, there is creeping creatinine from 1.7 to 2.4. There is graft dysfunction. So POD 3 months. So 3 months post-transplant, this patient has come with rise in serum creatinine from 1.7 to 2.4. Okay. So when you look at this biopsy, you see these tubules. Yes, Dr. Utkarsh, please carry on.
I think, sir, he is not there.
So, Dr. Millie,
No, sir.
They are resisting. Yes,
Sir.
they leave the section.
Hello.
So I'm signing.
hello. Yes, Dr. Millie, please carry on.
Sir, this photomicrograph shows various tubules, some distended tubules, few glomerulus, two glomerulus, and a few distended tubules, and some atrophic tubules, and in the interstitium shows inflammatory cells.
Okay. So, Dr. Millie, I'll run through this case. Dr. Jairam, sir. Dr. Jairam, sir.
Yeah, Rajan.
Sir, I'll rush through the next two cases. There is something urgent thing at my place, so I need to leave in 5-10 minutes, sir. So I'll rush through these two cases, next two cases. Yeah. So,
Sure.
so this is a biopsy which shows that there is some interstitial infiltrate which is there. Okay. And this is a pH stain which shows these casts. Okay. And these tubular casts are, as I go to high magnification, these tubular casts are showing a lot of reactionary stuff to these tubular casts is going on. That means it is an exogenous material and there is an inflammatory reaction to this exogenous material. Okay. As you can see here, so there are some fractures, fragments in this cast material. So whenever there are fractures or fragmentation in the cast material and there is a there is a inflammatory reaction to cast material, that means these are exogenous casts. These are not like they are made up of some exogenous material. And when we look at kappa lambda, so lambda is showing 3+ staining and kappa is like trace. You have to remember kappa is always more than lambda. So when you see lambda which is significantly more than kappa, at least in the tubular cast, that means it is pathological. The other thing is, look at these tubular basement membrane. Tubular basement membrane is showing 2+ kind of staining in the tubules, and there is a trace to minimal staining, or trace, I would say, negative staining along the tubular basement membrane for kappa. So that also suggests that possibly, when as I've told you in my globular lesion, in the globular lecture, that there is one pattern of staining which is called as linear pattern of staining, which you get to see in anti-GBM disease. But linear pattern of stain you can also see in light chain deposition disease. The only difference is in anti-GBM disease, the linear pattern of stain is seen along the globular capillary wall, whereas in a light chain deposition disease, the linear pattern of stain is seen along the tubular basement membrane. So this is another view to highlight that you can see these tubular casts, which are very trace kind of staining, and these tubular casts are showing 3+ staining, and the tubular basement membrane is also showing 3+ staining, and it is not staining with kappa. So that suggests there is light chain restriction, and it is a cast nephropathy because the casts are showing staining, light chain restriction, and the casts are showing those fragmented cast with inflammatory reaction, and the tubular basement membrane is showing a linear staining with lambda and no staining with kappa. That suggests that there is an early light chain deposition disease. So the diagnosis of early light chain deposition disease is made based only on the immunofluorescence findings. Otherwise, I would have labeled only as a cast nephropathy on morphology. Okay. So what I want to highlight is this patient was transplanted and it was thought that this patient is the basic kidney disease was thought as diabetic kidney disease. The biopsy was not done, and this patient was having underlying myeloma, plasma cell neoplasm, which he was not evaluated for. Okay. Sir, you want to add something, sir?
No, please carry on.
Okay. So we go to the last case. 56-year male with long-standing hypertension and subnephrotic proteinuria. Serum creatinine is 1.9. Urine routine microscopy showed 2+ proteins, RPC occasional. So if you look at this biopsy, it is showing these glomeruli, the vessels, which are showing narrowed lumen, completely narrowed lumen. Okay. You can see the glomeruli. There are ischemically wrinkled glomeruli, which are there. And you can see these vessels, which are showing a lot of halanosis. Just a moment. 5 minutes रुको 5 minutes मैं आ रहा हूँ 5 मिनट में हाँ आ रहा हूँ sorry so there is ischemic wrinkling, there is a lot of halanosis in these vessels, and if you look at these glomeruli, there is expansion of the urinary space. The vessels are showing luminal narrowing. And it is a very common thing you come across whenever these patients have malignant or accelerated hypertension. There will be ischemic wrinkling. There will be vessels which are showing this kind of. You can see there is a lot of duplication of the internal elastic lamina which is occurring. Normally, the vessel has this intima. The lumen is there, and then from here to this place is intima. So in intima, there is a lot of duplication of the intima which is occurring. So it is hypertensive nephrosclerosis with thrombotic microangiopathy. When I say thrombotic microangiopathy, look at these vessels. They are occluded by thrombi, okay? And the other thing is, look at these vessels. They are showing necrosis of the vessel wall with halanosis. So all these findings suggest thrombotic microangiopathy. And these are the endothelial cells which are showing a foamy kind of appearance, okay? So it is hypertensive nephrosclerosis with so 55-year-old male. So I'll just rush through this case. Post coronary angiography, sometimes you can see vascular pathologies, not very commonly. What you can see here is this is a vessel. This is a vessel, and you can see these cholesterol clefts within the vessels and these glomeruli which are globally sclerosed. Okay, and there's a high magnification of the vessel which shows these cholesterol clefts, and there is some giant cells around this cholesterol clefts. You can see this cholesterol cleft with the giant cell reaction. So it is classical of atherosclerotic renal disease.